NNF IAPS collaboration, I think Dr. Bajpai started this initiative, and I think it should only go from strong to stronger over the years. And I think the first meeting is, having a very good topic, very good panel of speakers. So I think, we will have a great collaboration in future for such meetings. It's been a dream of a lot of us to have a meeting between NNF, IAPS and all. I think this should continue on a quarterly basis if possible. What do you think, Agidikesh? Yeah.
Right. I think someone need to mute herself. Yeah.
Dr. Jessica, Jessica, please mute.
Yeah. Thank you very much. Dr. Ramesh Babu is the president of Indian Association of Pediatric Surgeons. And we really feel very honored to welcome all the speakers, moderators, as well as all the members of the Indian Association of Pediatric Surgeons and National Neonatology Forum. So without wasting much of our time, I'll hand it over to our moderators, Dr. Kanishka Das, who is a senior professor pediatric surgery, and Dr. Rajiv Redkar, who is himself a liver surgeon. Sir, please proceed with the further.
So is Dr. Kanishka Das?
Yeah, he has joined.
Yeah, Dr. Redkar. Go ahead.
Wonderful, Kanishka.
Yeah,
so
I've joined. Please go ahead, Dr. Redkar.
No, I think let us begin now. So I think without wasting much time, it's a brilliant, seminar. And I welcome one and all to this initiative of the Indian Association of Surgeons with NNF. So let us begin with the first speaker, Madam Uma Maheshwari, who is a neonatologist and an intensive care consultant and a specialist in inborn errors of metabolism. And she is a professor and head. Madam, can you go to the previous slide, please? SRMC Medical College, Chennai. So over to you, madam, for your talk as scheduled.
Am I visible? Am I audible?
Yeah, you are both, madam.
Yes. Good afternoon, Wanda. Hello, sir. Good afternoon, everyone. It's I would like to thank for the opportunity given by both NNF team as well as IAPS. So without wasting much time, I would like to go into the topic because we have 4 topics to cover for the evening. So my topic given was workup of prolonged neonatal conjugated hyperbilirubinemia. Dr. Smita, can you please mute? Yeah, thank you. So, what is my objective of this session for the next 20 minutes would be to understand the etiology of prolonged jaundice. So, unless we understand the etiology, the workup, we may not be able to kind of proceed with the workup and also learn how to evaluate prolonged conjugated hyperbilirubinemia. There are a lot of myths and facts. There are a lot of myths, I would think, in terms of how to define what is a direct hyperbilirubinemia. So it could be the direct bilirubin, some might say more than 1.5, whether when it is more than 15% or when the direct bilirubin is more than 2. So these are some of the myths. But the fact which we are taking by and large is when the direct bilirubin is more than 1 milligram per dl, so we take that as conjugated hyperbilirubinemia. And also, if the bilirubin levels are more than 5, more than 20% is taken as significant direct hyperbilirubinemia. So when we are talking about direct bilirubinemia versus conjugated hyperbilirubinemia, so I would like to bring in this particular aspect, namely are both one and the same. So generally conjugated bilirubin cannot be measured directly. So when we use the DIASO method, some of the unconjugated bilirubin also can react directly, which can overestimate the direct hyperbilirubin fraction. As such, But however, for all practical aspects, we take direct bilirubin is equal to conjugated bilirubin. But we have to understand the fact that the direct bilirubin, whatever is given by the lab, contains some amount of unconjugated bilirubin fraction also. We want to have an accurate measurement, then HPLC is the way forward, but it is not cost effective, so it is not by and large recommended. So when we are, as a neonatologist, when we see babies in the outpatient department, so what is the missed opportunity which is there? So a well neonate presenting with prolonged jaundice. So we might take it as, okay, it could be because the baby is being breastfed exclusively, and we take it for granted that, like, okay, can persist. But however, you have to put a break when it is persisting for more than 3 weeks, even in a well-appearing breastfed neonate. And also, whenever it is a new onset or whenever there is an increasing severity, we need to take it significantly. When we ask, whenever there is a prolonged jaundice, we always ask the urine color and stool color with the mother. So they could say urine color colorless and stool color is yellow. But however, the stool color is not a sensitive marker. So there are like a lot of stool charts prevailing, which can be used as a screening tool, which we can show to the parents and say, if they say it as yellow, is it like bright yellow or is it a dull yellow? Because they might mention both dull yellow and bright yellow as yellow. And also, like by using a stool chart, we are making a subjective assessment to an objective assessment. So overall, by and large, if you have a 2,500 babies born in your unit per year, you should be seeing at least one neonatal cholestasis in the year. So for that, like, you know, you need to make a significant attempt in evaluating all the babies presenting with jaundice in your outpatient department after 3 weeks of life when it is visibly jaundiced. So before we move on to how to evaluate further when you see a jaundice, so is there any newborn screening available? So there are a lot of attempts done. So this is one of the diagnostic yield of newborn screening for biliary atresia published in JAMA. So because we all know that biliary atresia has to be diagnosed and the treatment has to be proceeded before 45 days for a best outcome, or at the most 60 days. There are like a lot of Asian countries, so some of the US territory provinces which do this newborn screening. So what they do is they do as a two-tiered approach. So whenever the baby is in the unit, around less than 96 hours of life, they do the newborn bilirubin testing. In that, they take the 95th centile. Whomever is falling above 95th centile, they do the second tier testing or second stage testing, namely the fractionated bilirubin, and they take significantly whenever it is more than 1 milligram. And they found that in their 1.2 lakh population of newborn, they had 7 biliary atresias with a 100% sensitivity and 99% specificity. So 100% sensitivity and 99.9% specificity. With a very good negative predictive value. However, the positive predictive value is less than 6%. So maybe one of the way in which the training can be attempted. So before I move on to the etiological aspect, I would like to unfold the fact that whenever there is problem with the bile formation or bile flow, it is significant. So when we say as bile, so the composition of bile, the bilirubin is only 3% of the bile composition, but bile acids, cholesterols, and other fatty acids makes the rest of the bile composition. So that is why we need to, if at all we are finding a conjugated hyperbilirubinemia, we have to automatically ask for lipid profile as well as the bile acids level. So this is the biliary tract. Like, I'll try to zoom. Okay, so doesn't matter. So this is a biliary tract. So we can see the intrahepatic portion of the biliary tract and the extrahepatic portion of the biliary. So the bile which is formed through the intrahepatic trees, so they get the flow happens and gets stored in the gallbladder, and then the flow happens. So obstruction either in the extrahepatic segment, or there is a problem with the bile production or bile flow or bile duct paucity in the intrahepatic portion can cause direct hyperbilirubinemia. So this is the hepatocytes and cholangiocytes. So the cholangiocytes is the cell where bile is produced as such. So this is a complex, the cholangiocyte is being zoomed here. There is a complex flow and transport system which is involved in the formation of bile. So you will know like why I am insisting on that bile formation later on, like when we go for the evaluation. So
Any problem, madam?
no, I'm just trying to take off the.
May I help you, ma'am?
So I'm just trying to take off the video panel. Okay, sorry, I got it. Sorry about it. So whenever we have an algorithm of neonatal cholestasis, it can be in the extrahepatic bile duct or in the intrahepatic bile duct. So when it is an extrahepatic bile duct, it can be a biliary atresia or choledochal malformations and gallstone sludge. Whenever it is an intrahepatic, it can be due to bile duct paucity. It can be increased canalicular flow or dysfunctional plasma membrane transporters or hepatocellular injury, which can in turn be due to infection, drugs, IEM, and idiopathic. So this algorithm is important, and it is, we could classify as treatable, non-treatable, surgical versus non-surgical, genetic versus non-genetic, biliary atresia versus others, because these are by and large the etiology for your direct hyperbilirubinemia, namely like biliary atresias, inherited syndromes, alpha-1 antitrypsin deficiency, but however, it is more common in the West than in Asian population, viral infection, neonatal hepatitis, metabolic, and others. So initially, the neonatal hepatitis was occupying a wide spectrum, namely idiopathic neonatal hepatitis. Now, because of the current genetic evaluation being done, the spectrum is coming down and down. Maybe like we might not find it once the genomic testing is becoming more robust. So we have armamentarium for evaluation. It could be ultrasound, it could be genetic, basic blood tests, liver biopsy, or scans. How are we going to go about it? The first and foremost, as a neonatologist, I think history and physical examination is very important. History could include a family history of consanguinity, where we could think of genetics, sibling with cholestasis, fetal loss, which can point out towards gestational associated liver disease. And antenatal period, mothers sometimes can present with cholestasis of pregnancy, which can, or fatty liver of pregnancy, which can indicate some of the FAOD, fatty acid oxidation defect. Some of the antenatal scans can detect choledochal cyst, and maternal infection is something which we should ask from the mother, because torch infection is one of the etiology for neonatal cholestasis. Coming to the neonatal history, so preterm, they are at more risk for idiopathic hepatitis. SGA, we could think of torch infection. If there is a vision abnormality, it could be a septo-optic dysplasia and hypopituitarism. If there is a hearing problem, it could be PFIC, which is progressive familial intrahepatic cholestasis, or it could be a mitochondrial infection. UTI is the most common cause for conjugated prolonged hyperbilirubinemia. And also nutrition in terms of TPN. If baby is on TPN, we know the etiology already. Examination, it is very important for us to know whether it is a well-looking or ill-looking baby, because majority of the biliary atresias are well-looking, at least in the initial phases. Biliary atresias with malformations can be ill-looking. So dysmorphism, it can be either a syndromic like Zellweger syndrome or Alagille syndrome. But however, Alagille syndrome does not present with dysmorphism in the neonatal period. Usually they present with dysmorphism around 6 months of period. Systemic examination, we should hepatomegaly is there, whether there is any signs of liver cell failure or any stigmata of starch infection should be looked for. Features of liver cell failure, again, I already mentioned. Cardiac failure, it could be a part of Alagille syndrome, which presents with cardiac failure, or biliary atresias presenting with heterotaxy and sometimes cardiac malformations can present with cardiac failure. Slit lamp examination would point towards posterior embryotoxon in Alagille syndrome. Retroflex will rule out a cataract in Zellweger and galactosemia. We should also ask for a formal hearing assessment. Most important thing, maybe we might be missing, but it is just a stool, we can ask history, but it is very important for any physician to look at the stool color and decide like how much acholic it is. And the stool examination is important as a part of examination itself. So coming to the algorithm, so how we are going to proceed about it. So, and alpha-1 antitrypsin deficiency, that's very common in breast. So they rule out in terms of serum alpha-1 antitrypsin in the initial phases itself by electrophore, or they do an electrophoresis. But having said that, in Indian, Asian countries, it is not that common. Blood and urine culture, it might be depending on if the baby is not looking good, we would be doing a septic workup. Newborn screening. Newborn screening, it is the newborn screening, what they do in different places are different. We do an extended newborn screening for all the newborn born in SRMC. So we do a TMS test and also rule out galactosemia and thyrosemia and hypothyroidism in the beginning itself. But if your unit is not doing newborn screening, maybe these may not be coming under newborn screening, but you should be evaluating for galactosemia and thyrosemia separately. But I suppose that all of us will be doing an universal screening for thyroid. So ultrasound abdomen would straight away rule out a mass or choledochal cyst. Then you look for any red flags for specific etiology. So if there is a specific etiology, it could be hypopituitarism, there could be midline defects, or there can be stigmata of congenital infection or Alagille syndrome, or there could be features of IEM or mitochondrial disorder. If everything is negative or you do not find any of these things, then a liver biopsy is indicated at this stage to look for bile duct plugs or proliferation and fibrosis, followed by intraoperative cholangiography to diagnose biliary atresia. If there is a non-specific finding, either at this stage or here, there is a role for genetics. It can be a targeted gene panel, or it can be a whole exome sequencing, or sometimes even a whole genome sequencing for detecting both known metabolic disorders and novel disorders. I think once I go to the case scenarios, you will be able to understand the role of whole exome sequencing, how far it is being utilized. So by and large, there are two tiers of test. Tier 1 test is to understand whether there is any treatable condition and also to understand the severity of the liver involvement. So tier 2 would include baseline investigations of complete blood count, LFTs, including gamma GT. So when we ask for LFT, sometimes they may not do GGT. So we have to specifically ask for GGT. And also total and direct bilirubin. So this will be the initial point of assessment. So whenever we are having prolonged jaundice for more than 3 weeks, we will be asking for this particular bilirubin, direct and total bilirubin fraction. And whenever the direct portion is more than 1, that is when we are going to take it as significant and follow the algorithm. Again, for liver functions, it could be an albumin. Thyroid functions, we can evaluate the newborn screening. So urine analysis and reducing substance, blood culture, urine culture, and also newborn screening assessment, and then obtain a pre-feed ultrasound. So when we go to the what could be the utility of baseline investigation? So these are all only baseline, whether it can point towards any specific abnormality. So your gamma GT will be high in biliary atresia, Legales, and PFIC, but like low gamma GT, that is what we are looking for. So that can happen in PFIC 1 and 2 and 4, 5 and 6. And also hypopituitarism and bile acid synthesis defect. So low gamma GT is something which we should be looking for. And also liver dysfunction can be by synthetic functions, namely hypoalbuminemia, hypoglycemia. And also if the prolonged coagulopathy is out of proportion to the liver dysfunction, say for example, you are doing a HCOT, PT, etc. So that is not kind of favoring the liver dysfunction, but your coagulopathy alone is very significant. So then you have to think in terms of GALT, metabolic disease or sepsis. AST elevation with a normal ALT. You all know that ALT is more specific for liver. AST is more for muscle. So if AST is elevated more and with a normal ALT, it can signify a muscular or hematological parameter. So hematological parameter by and large presents with conjugated hyperbilirubinemia, but however it can have like some amount of inspissated bile syndrome, which can lead on to direct hyperbilirubinemia. Moving on to ultrasound, it can detect just a visible abnormality, which is just spiking in front of the eyes, namely choledochosis or like some visible obstructulation of the bile tract. But again, it can be useful for seeing how is the ecotexture of the liver, whether there is any features of advanced liver disease. Also, if there is a biliary atresia with malformations in terms of abdominal heterotaxy, midline liver, or asplenia, polysplenia, and also pre-duodenal portal vein. So these are all increasing the chances of biliary atresia with malformation. Maybe a simple X-ray also would help us to determine abdominal heterotaxy as such. So moving on to what is the role of ultrasound in detecting biliary atresia, we could find a triangular cut. So you can see here, this is a portohepatis where you are seeing a triangular cut sign. And also the Doppler might help us to detect the hepatic artery portal vein diameter ratio. And also it can detect gallbladder morphology in terms of lack of gallbladder contraction and other parameters, namely non-visualization of common bile duct. All these signs, namely triangular cord sign or gallbladder abnormality or the ratios which we spoke, might aid in the diagnosis of biliary atresia but cannot confirm. That the triangular cord sign diagnostic sensitivity is only around 73%. So moving on to the tier 2. So what is a tier 2? We are going to complete the evaluation and like that should be occurring in concurrence with help of pediatric gastroenterologist or hepatologist. So that would include a serum bile acid levels and cortisol levels, complete the metabolic profile in terms of GALX, which stands for glucose ammonia lactate, ABG ketones and reducing substance, and also GALT enzyme levels and urine succinyl acetone and organic acid. And infectious disease, we could look for a PCR-based technique. Here comes genetics, definitely imaging studies, namely spine, echo test, and a liver biopsy. So what is the role of liver biopsy and other scintigraphies? This is a study which is done in 2009 and published in Clinical Imaging, comparison of different diagnostic methods for differentiating biliary atresia from idiopathic neonatal hepatitis. So here they had 69 infants, all of them underwent everything, like MRCP, hepatobiliary scintigraphy, SPECT and liver biopsy. In that, they found that the hepatobiliary scintigraphy has only a sensitivity of 88% with an even more lower specificity of only 45% with the diagnostic accuracy reaching only 2/3. So they concluded that it adds little. Maybe liver biopsy had the highest sensitivity of 100% with the highest specificity. Following which, there was a systematic review and meta-analysis done in 2013, where they included around 81 studies, and the pooled sensitivity and specificity of hepatobiliary scintigraphy was around 90% and 70% respectively. So again, what is the role of ERCP? This is published by Dr. Naresh Shanmugam and team from Chennai. So they had they evaluated the role of ERCP. So they found a very high positive and negative predictive value for diagnosing biliary atresia. But however, this endoscopic retrograde cholangiopancreatography needs an experienced endoscopist, specific in endoscopy equipment, and may not be readily available in all. So biliary atresia could be different types. I'm not going into detail, but the PTCC or percutaneous transhepatic cholangiocystography will not detect this kind of type 2A as such. So taken together, they say that it has very limited role. So the gold standard remains as an intraoperative cholangiogram and histological examination of the duct. So again, liver biopsy, they look for inflammation, architecture, and something called as bile duct to portal tract ratio, which should be normally more than 0.5. So now that we understood the importance of extrahepatic bile duct and bile duct paucity, how do we go about this decreased canalicular flow or hepatocyte injury? So this is one of the complex diagram of transport of bile. So you can see from here, I'm not going to go through this, but you can see from here, it is a very complex procedure with lot of transport proteins which are involved here. And this is a list of genetic and IEM. So it's not a surprise that because it's a complex process, you have canalicular flow causing many abnormality as such. So these are the IEMs by and large which presents with liver cell failure. So if you take within 1 month, it can be GALT, neonatal hemochromatosis, and mitochondrial urea cycle disorders, galactosemia and thyrosemia. So up to this can present in the newborn period itself, because they present mainly with liver dysfunction along with direct hyperbilirubinemia as a part of liver dysfunction. Whereas bile acid synthesis disorders, peroxisomal disorders, and cholesterol synthesis and transport, namely Niemann-Pick type C, citrin deficiency, alpha-1 antitrypsin, and progressive familial intrahepatic cholestasis presents predominantly only with cholestasis. So how do we diagnose all these things? We have specific diagnostic evaluating marker, namely we could, after GALAC, we should be doing a TMS, plasma amino acids, and also very long chain fatty acid effect. PFIC, again, we can detect only by molecular evaluation. So moving on to cases. So there are few cases which will tell the importance of how to evaluate. So it's a 22-day-old male neonate presented to outpatient with increasing severity of jaundice. Evaluation showed conjugated hyperbilirubinemia with elevated transaminases and significantly elevated GGT, which was 20 times more, with hypertriglyceridemia. He was born and diagnosed to have TOF, tetralogy of Fallot, and immediately discharged home. Liver biopsy was done and it showed a bile duct to portal tract ratio of 0.7. So what is the likely diagnosis and what will be the confirmatory testing? So now we have certain clues here. There is conjugated hyperbilirubinemia and there is a congenital malformation. So there could be potentially many possibilities. If you take PFIC, it will not have cardiac. If you take discharge, it will have cardiac, but may not have that much elevation of gamma GT. So Alagille syndrome is the best fit, which can, have all the features labeled here. And remember, very high gamma GT, 20 times more than whatever is the normative value, is more suggestive of Alagille syndrome. And also we need to remember that, as I said earlier, the Alagille syndrome presents with dysmorphism only after 6 months. Moving on to case 2, it's a 4-week-old female neonate admitted unwell with severe jaundice and liver cell failure. On evaluation, she had conjugated hyperbilirubinemia, grossly elevated transaminitis, urine positive for reducing substance, normal bile acids level, near normal tyrosine, and elevated urine succinyl acetone. So,
Excuse
whenever
me,
we
madam.
think,
See, I'm getting constant messages that the time allocated has got completed. So,
Yes, sir.
shall we leave off the cases for discussions later? Because we have
Yes, sir.
already consumed, half an hour, and it's
Okay,
a
sir.
2-hour slot. So, I'm sorry to interrupt you, but cases we could discuss at the end if the time permits, if you don't mind.
No
Is that
problem,
okay,
sir.
madam? So, do you have a message slide in the end that you could conclude?
Yes, sir. So this is again my take-home message. So you can see that, like, if you come to the algorithm again, so you can do an ultrasound culture. You could look for specific etiology, liver biopsy, intraoperative cholangiography, stage bilirubin among prolonged jaundice, targeting interruptions. So identification of direct hyperbilirubinemia among prolonged jaundice, stepwise systematic approach, and role of genetic and metabolic testing in finding the etiology. Thank you.
There is, Dr. Redkar, there is one question in the chat box.
Yeah, but then
which
I don't
madam
think we
can
have
take.
time. Since we have finished
Okay.
the half an hour. Okay, do you want to? I am also given a message that there is a secretary of the NNF, Dr. Surendra Bisht. Is he on? Is he online? He needs to speak a few words, and then we could. Kanishka, you could introduce the speaker, second speaker.
All, and I'm really thankful to all of you, and I'm really glad that a big CME is being done today with as a collaborative effort between Indian Academy of Pediatric Surgeons and National Urology Forum. And thanks Uma to represent NNF here, and Dr. Anupam Sibal is waiting next on the line. He is the medical director at Apollo Delhi, and he asked me, am I going to sit for 2 hours? I said, no, sir, you can come later also. But I'm looking at Dr. Anupam Sibal is still here. Hi, Dr. Anupam. Thank you. He's there for last one hour or so. Thank you. And it's great. Please, Dr. Ramesh, Dr. everybody who has done it, and I'm really great. It's a great movement for all of us.
Thank you so much, Dr. Bisht. Okay. Dr. Kanishka, I hand you over for introducing the next speaker, please.
The next speaker is Dr. Zamir, or is it Dr. Arvind Sinha?
Dr. Arvind
Sinha. Dr. Arvind Sinha. Okay. So Dr. Arvind Sinha is a professor at AIIMS Jodhpur, and he's well known to many of us. He has qualified from Maulana Azad Medical College, and he has an abiding interest in many fields of pediatric surgery, one of which is, of course, hepatobiliary. He has also made forays into administrative arenas and has excelled himself there. So I will not take more time, and we go over to Kasai's photoenterostomy. I'm sure he will deal with important technical aspects and how it reflects on management and outcome on these children. Dr. Arvind Sinha, over to you.
Thank you, Kanishka, sir. So it's indeed an honor to be here and presenting about Kasai's photoenterostomy. Right, it's a mixed audience, and I think technical points and long-term results are required to keep the attention of everyone present. So our objective is basically to give a brief history and evolution of Kasai's photoenterostomy, intraoperative cholangiography, and any alternatives that are available, the technical steps, and what is the science, what is the available science regarding each step, and some of the factors affecting the outcomes and in brief about the long-term results of Kasai's photointrostomy. So I think let's get into it. So it was in 1968 that actually Kasai described this photointrostomy. This was the first definitive entirely surgical management of intractable condition that led to death of the babies within the first 1 or 2 years of life. So the morphological Japanese classification divides it into type 1, 2, and 3. Type 3 is what is most commonly seen. Type 1 and 2 are the correctable type that that has been described. I have never had personal experience with type 1 and 2. When I started off, the two major questions that we used to ask is when to operate, and I think 90 days was the standard at the time of my MCS. They operate within the 90 days, and you'll have a better outcome as compared to, let's say, later. And the second question that we used to ask is, when is it too late to operate? Patients used to present at 4 months, 5 months. And the question was, should we operate or leave them? Results are poor and that kind of stuff. So once the diagnosis has been done, the patient has been referred to our surgeons, we go ahead and do what is known as an intraoperative cholangiography. We give a small incision in the subcostal region, and then the first thing that we do is basically to inspect the gallbladder. If it is rudimentary, fibrous, no lumen, we definitely directly proceed with Kasai's photointrostomy. However, if the gallbladder appears to have a lumen, then we secure a purse string and we do an aspiration of the gallbladder itself. If there's no bile or white bile is present, we proceed with Kasai's directly again. In a small subset where we can actually find bile, then we have to go ahead and do an intraoperative cholangiography. So the first thing that we have to look for, whether the contrast flows into the duodenum once we inject it into the gallbladder. If there's no flow into the duodenum, biliary atresia is confirmed. If there's flow into the duodenum, then we have to, again, as a second step, look at the contrast flow into the intrahepatic bile duct. If there is flow into the intrahepatic bile duct, our biliary atresia is excluded. If it is not, some maneuvers can be attempted, but we generally would go ahead with the Kasai photointrostomy. Now, intraoperative cholangiography is a little difficult, simple to perform, but it's often very difficult to interpret because gallbladder is sitting right on top of the bile duct. Radiology is difficult, sometimes spills occur and basically obscures. So a purse string is required to prevent leakage. The contrast material itself is viscid. We use, if you dilute it, it flows a little bit more easier and goes up and down easily. And real-time fluoroscopy also helps with intraoperative cholangiography. Both these examples show biliary atresia, even though gallbladder can be visualized in the first series, and in the second series, contrast is going directly into the duodenum. However, intrahepatic bile ducts are not getting seen. So those are both examples of biliary atresia. Alternatives, as the madam has already mentioned, ERCP has been used as an alternative to intraoperative cholangiography and has found reasonable sensitivity and specificity with technical failure which are acceptable of 5 to 6% or 7%. Similarly, percutaneous transhepatic cholangiography has been used. Jensen in 2012 was first to suggest that PTC with liver biopsy may be an algorithm, arm of the algorithm for excluding biliary atresia as opposed to IOC. Para in 23 used PTC for diagnosis of biliary atresia, and Suchka suggested it can be used in patients where we cannot do the surgery, who are high-risk patients for intraoperative cholangiography. We might use PTC and rule out biliary atresia. Once we've gone on to the path of Kasai's photointrostomy, we give a generous incision, we mobilize the liver, deliver the liver into the wound, and proceed with the portal dissection. And we expose the portal fibrous substance which is there, mass which is there, right? Kimura in 79 actually tried to define where we have to cut this mass, the depth of the dissection, and basically came up that the portal area is the right place to cut. Supraportal or infraportal led to extremely poor outcomes. So with regard to the extent or width of the dissection itself, Kasai described the original Kasai, but it was modified by Kasai himself as modified Kasai, and then surgeons modified it to an extended Kasai, where a much larger area were dissected out and used for portoenterostomy. Then after this is beyond that, we'd go ahead and do the portoenterostomy, where a rule loop is taken and end to side portoenteric anastomosis is done. So is there any literature between modified Kasais and extended Kasais? Limited data is available, and this data is basically coming from centers which are doing laparoscopy. Yamataka has been publishing papers on modified versus extended Kasais, and he suggests that a modified Kasai has a much higher jaundice-free rate and much higher native liver survival as opposed to extended Kasai, which is done in open procedure. So he basically suggests the modified Kasai is better because the risk of damage to micro bile ducts around porta hepatis is minimized, because deep suturing and extensive dissection are eliminated in modified Kasai. So similar results are shown for modified Kasai and extended Kasai, and modified Kasai he suggests is better. However, we have to take it with a pinch of salt, because all the registry data for open surgeries are based on extended Kasai, especially the Japanese registry data. So this is what I had said about Kimuras, where portal depth of dissection at the level of the porta he had suggested. There's a study by Neo which also tried to define the depth of dissection over a 4-year period. And they divided the groups into each decade into four decadal groups, group 1, 2, 3, 4, where group 1 and 2, where the fibrotic portal mass was cut outside the level of the capsule, they had 66 to 70% jaundice clearance. When they tried to go in deeper into the liver parenchyma, their jaundice clearance rate actually dropped to 63%. And when they stopped at the 4th decade, when they stopped right at the level of the capsule, they had a much higher 87.2% jaundice clearance rate. So probably at the level of the capsule is what is now the accepted science with regards to depth of dissection. Then rule loop preparation generally is standard, is 40 centimeters, the standard which we have been taught, we have been using. However, in the Japanese biliary atresia registry, they did a subgroup analysis of patients which had a lower than 40 centimeter rule loop with longer than 40 centimeter, and found no difference in cholangitis rate. Similarly, anti-reflux valves and exteriorization using Suruga have been used, but there is no difference with regards to jaundice or cholangitis in any of these with any of the technical modifications. The question can arise, is even shorter loop better? Randomized controlled trial was done, which basically aimed to define if we could use a shorter loop and not have more cholangitis and have acceptable jaundice clearance rate. And they found that the results from a long rule loop and short rule loop were absolutely similar. And they had utilized a rule loop of only about 17 centimeter, which was just enough to reach from the jejunum mesentery to the porta hepatis, nothing more than that. And that had acceptable or similar result in a large series of patients. So once we've done the portoenterostomy, we send that the mass that we have, the portal mass for histopathology. What do we look for in histopathology? Is basically ductal proliferation is the hallmark of biliary atresia. We look at fibrosis, cholestasis, bile duct size, morphometry can be seen, but bile duct size at porta hepatis and histological hepatocellular swelling are independent predictor factors for post-Kasai outcome. So one of the studies has suggested less than 150 would size of bile ducts at the porta will have poorer outcome. Newer studies in 2022 are coming up with 50 mm, less than 50 mm and more than 50 mm as split between good results and poorer results outcomes. Then the other question is age of surgery and outcome. I've alluded to that 90 days was the initial cutoff when we were doing MCHs. It has migrated, evolved to 80 days, 60 days, 40 days. Nowadays, I think we will cut off. Japanese registries have operated average age at 59 days. our recent literature is suggesting that best results are done if the surgery is done within the first, in the neonatal period itself. So let's discuss age of surgery and the jaundice clearance rate. Jaundice clearance rate is highest if it is done within the first month of life. It is jaundice clearance rate is about 70% in the first month. It remains relatively stable till about 80 days of life to 60%, and then it starts decreasing and decreases precipitously after 120 days. So the French and the native liver survival and age of operation, the French and Japanese cohort basically have said native liver survival advantage is most marked again in the less than 30-day age group. And the difference between the youngest patients operated and the oldest operated patients is about 50 to the tune of about 20%, 15 to 20%. So that's the hit that we take or the patients take for a delayed surgery. Again, age of surgery, 25-year native liver survival within 30 days is 37%, and beyond 90 days is only 18%. Are there any patients where we should not be operating? Age alone, the literature suggests the age alone is not a contraindication to doing a portoenterostomy. Poor general condition, late presentation with cirrhosis, hypertension, pulmonary syndrome, pulmonary hypertension. Those patients probably might not benefit from a surgery itself. My general rule is any patient we take up for portoenterostomy should be able to survive the surgery, should not land up with adverse outcome. So we have to look at very carefully which patients to operate, but I think 90-95% of patients should get the portoenterostomy. Then again, a question can be asked whether to do a Kasai's portoenterostomy or at 3 months or beyond, or offer no surgery and go for primary liver transplantation. Fuchs, in a large study of 424 children, basically compared late portoenterostomy with no portoenterostomy, that is primary liver transplantation group. 2-year native liver survival in late portoenterostomy group for 53% as opposed to 12% in the no surgery group, and 5-year native liver survival, even in the late portoenterostomy, was 30% as opposed to 4%. So if you look at the overall survival, we can see the red line itself is the late portoenterostomy group, and that is hugging the blue line of early portoenterostomy, and whereas the green line, which is of the no portoenterostomy group, that is lagging way down below. So overall survival is definitely better if we give up portobiliary drainage. Similarly, native liver survival also seems to be better if we do a portoenteric anastomosis. Long-term native liver survival, the French national study is one of the largest and one of the longest studies over 40 years, 1428 patients, and they have operated about 1340 patients with Kasai's portoenterostomy, and they have required to do a liver transplantation in about 55% of their whole cohort. At the 20-year native liver survival, they have said is about 26% will survive around 20 years. So let's look at the Japanese results as compared to the French results, how are they compared. So if we look at the Japanese biliary atresia registry, they have a liver transplantation rate of only 39%, which is much lower than the French liver transplantation rate. And similarly, native liver survival for Japanese biliary atresia registry is almost double of the French, which is about 49 to 50%, which is head and shoulders above what French results are demonstrating. So what about the long-term results of native liver survival? Yes, it is definitely possible for a native liver to survive beyond 20 years. Bijul in 2013 did a systematic review, had about 160 patients and with 20-year survival, and he reviewed papers and found about half of 60% will have progressive liver-related complication, even though they are surviving on the native liver itself. So some element of liver problems like splenomegaly and varices and bleeds and all that, that is still continuing with those patients. So in the end, I think take-home message, Kasai's portoenterostomy should be offered to all except for a very small minority of patients which might not be suitable candidates. There is wide disparity in literature and results. Basic thumb rule is earlier the surgery, the better, and it may avoid liver transplantation altogether in at least half, if not more, if the child is lucky. Early diagnosis is key, and we should have a very low threshold for doing intraoperative cholangiography. Indian data, I was looking for it. There's a singular lack of Indian data. It's mostly limited to thesis studies, 3-year, 4-year kind of studies. Laparoscopic repair, modified Kasai, small loop might be the way forward for the technical aspect of Kasai's portoenterostomy, and sequelae of liver-related complications may persist even with long-term liver survivors. Thank you for your patience.
Thank you, Dr. Arvind. That was a nice recap of the current status too. I think there are 1 or 2 questions in the chat box. There's a comment that a shorter loop has problems in transplant later. I know how that is. Maybe Dr. Zamir could sort of. He has put up this comment that a shorter loop. I know that many of us do much shorter loops than 40. So how short a loop is a problem in liver transplant that one has to be careful about while doing the Kasai, especially in the late presenters.
Yeah, good evening, everyone. Sir, first of all, an excellent talk by you, Arvind, sir. And you brought out things about Kasai so beautifully, things make very clear. A small comment that generally whenever we do a transplant, especially post Kasai portoenterostomy, we use the same rule loop for our reconstruction. So what happens is when we use this, there is a small part of the rule loop which we actually have to lose, which is attached to the liver. So the part which is going up to the liver, we keep, and the rest of the part which is at the junction of the liver and beyond it, we lose. So what happens is, in case we have a shorter loop, then this small loop of intestine may not be adequate enough to come all the way till the graft to do the anastomosis. So that's when sometimes if you have a shorter loop, then we have to take down this rule loop and make a new rule loop. Most of the time, about 35, 40 is more than enough for us. But unless it's really short, only then it's a problem. But otherwise, generally, I think it should be fine.
I see. So 35, 40 is what you say. Right. Any other questions? There is the other point, Dr. Arvind, is despite so many studies, histopathology, the only thing that has actually stood the test of time is fibrosis and the grade of fibrosis, and just nothing else. The rest of them really don't come anywhere in the picture in prognostication. Is there any other thing, any other question that or comment that you would want to put forward, Dr. Redkar?
No, I think
I wanted to ask one question. Can I? Dr.
Yes,
Sushma?
please. Yes, please, madam. Go ahead, quick.
I wanted to know,
Please.
Dr. Arvind, what is your experience with patients of biliary atresia with the CMV infection?
They generally have much poorer outcome. They have stormy post-op period. Resolution of jaundice is much poorer. We need to give antivirals definitely, but they definitely we've done a study, and the cohort we found as a cohort they have much poorer outcomes.
Yeah, I think that is
Significantly
international experience also. True.
So in our experience, like CMV infection once detected, and appropriate valganciclovir, which is given orally now. Earlier it was only IV available. Now oral is also available. When we do that together with the Kasai, then the results are much better than only Kasai. Meaning CMV infections have to be diagnosed and they have to be treated appropriately. The entire regime goes on for many months. Actually, it is not just
6
days.
months.
And our experiences have been quite good. We have published papers also on this CMV infection in biliary.
Yeah, but I think the long-term results are still poorer with CMV even after optimal diagnosis and treatment.
So that again depends on the
still
cirrhosis, which
poor.
has already happened before the biliary atresia surgery has been done. So that is entirely, the long-term outcome is entirely dependent on the liver, basically.
Okay, right. I think we have a few minutes left. There was a comment from Dr. Sibble about CMV. Hope it is PCR positive. Yeah, maybe the neonatologist would give us a
Kanishka,
thing on this.
yeah, my question is that we quite often see a label of CMV hepatitis based on a CMV IgM, which actually is really dustbin. So, unless we've properly got a CMV, we see, before they come to us, a lot of wastage of days and weeks, and also very expensive therapy, which is not indicated. So, just a word of caution in that when we label someone as CMV, it actually should be CMV.
Yes. Yes.
Things
Kanishka,
like PCR,
can I
PCR
ask?
positive. Sorry, sir.
Yeah,
Can I
there's
answer
a
that question?
comment from the neonatologist.
Sir, I think like PCR positivity should be taken as CMV infection because sometimes there could be anamnestic reaction in terms of IgM, which can cross-react with other IgMs as such. Doing a PCR, either a urine CMV or salivary PCR should be done.
Yes.
And because sometimes we diagnose CMV, if there are features of biliary atresia, we should not delay the diagnosis, thinking or putting forward that it is only CMV infection. So if even
Right.
on treatment, it is not, there is no resolution of jaundice, then we should promptly put forward steps to go ahead with the diagnostic evaluation of biliary atresia because they can coexist.
Absolutely.
It is
Absolutely. That's a very
known to
important point.
coexist.
That we don't sit on the CMV, rather we treat both concurrently and quickly establish whether it's biliary atresia in the evolution also. Yes. Yeah, Dr. Edkar, over to you.
Yes, I enjoyed your talk, Dr. Sinha. My question was that the biliary atresia with splenic malformation, how many do you encounter? Do you find that as a possibility amongst the series of cases that you handled? And how do they generally do as an outcome survival in your experience?
I have no personal experience with biliary atresia with splenic malformation. I'm waiting for it to come.
Really? Okay. Well, because you did mention about the type 1 that you didn't see, but we see them once in a while. And I was wondering whether when the Western literature talks about poorer outcome, it may not be that consistent in our experience. I don't know what Kanishka has to say. Kanishka?
Yeah,
Anyway.
we have had few, but the problems that we have had in that has been largely technical about getting the rule loop, etc. properly. But we don't have really any data to say that it's been a worse prognosis, although the international experience is that the prognosis is in fact inferior.
Correct. Anyway,
right.
So I think we are okay for time, Kanishka. So
there is one question. There was one comment that the liver biopsy being non-specific, does it have any role? There was one comment in the chat box. I think the neonatologist or Dr. Sibbal could actually tell us where one would really consider a liver biopsy, because the surgeon's gung-ho approach is, yes, we go straight to intraop cholangiogram, which is justified in some context. Absolutely, there's nothing about that. But there are some very specific situations like a fluctuating jaundice where a liver biopsy might really help, not in the persistent jaundice, not in the persistent pale stools. Can we have a comment from the neonatologist and Dr. Sibbal both?
Uma first.
Yes, please,
Okay,
Dr. Sibbal.
sure,
go ahead. Go ahead.
So I think basically we need to look forward for stigmata of other disorders. History and evaluation might give us a clue. As I said, like a major chunk can be genetic, metabolic, it could be consanguineous marriage, etc. If we are not having any clues, I think the main basic principle is we cannot afford to waste time on it. Earlier it is better. So I would say that even if it is a negative thing, we might have to proceed for that. That is my thinking process as such. Of course, now the genetic evaluation has come a larger way. We can get a rapid exome sequencing or expedited exome sequencing, and it takes hardly 10 days for the report to come. So as soon as a prolonged conjugated hyperbilirubinemia is found, we parallelly counsel the parents as we are evaluating in terms of ultrasound, etc., because of the wider availability of whole exome sequencing and also the price drop of whole exome sequencing. We parallelly counsel for whole exome sequencing. By that, we have found out bile acid synthesis defect, TRMU mutations in mitochondriopathy, etc. We have found out.
So
Okay.
thanks, Kanishka. Great point.
Yes,
So
please, Dr. Subbu.
first of all, it depends on who's looking at the liver biopsy. I mean, does he look at a liver biopsy every day? Because if you're looking at 4 liver biopsies a month, then it's really not going to be good enough.
We are
So the
talking about the proper
histopathology, so
pediatric
non-specific.
hepatopathologist. Yeah.
No, you're talking about a
Even if you have a
non-specific.
proper pediatric hepatopathologist at the other end, clinically, it would be nice to know which are the ones in whom we have a good threshold for a liver biopsy rather than directly proceeding.
Sure.
Yes.
So you have someone with pale stools, you have a history that fits in well-looking baby. You got an ultrasound done by an experienced ultrasonologist who has the patient, shows you a triangular cord sign. What you're dealing with. You want to confirm the biopsy. You get a biopsy report. In our program, we get a biopsy report in 24 hours with all the special stains. So it's relatively easy. A biopsy has a definite role. I mean, areas where confusion happens and where we should make life easy for a pediatric surgeon before we refer is missing out on bile duct paucity. It's very hard for a pediatric surgeon to differentiate bile duct paucity on an IOC. And data from Stanford is shown with allergies. If you go ahead and do an IOC, you end up doing a Kasai, and then 70-80% of them with allergies will need a liver transplant, but if they'd been left alone, about 30% would need a transplant. So I think one has to look comprehensively, but just a word of caution about the biopsy. It has to be done in a center where the histopathologist is experienced. Just sending off to a random lab, you get a very random report.
Absolutely.
That's important. And the second thing is about a HIDA. We keep on telling pediatricians in the community, please do not waste 5 days in doing a HIDA. Please understand what is it that you're actually getting out of a HIDA. And I think there is a whole lot of awareness that needs to build up. And I feel terrible that 27 years down the road since we first started talking about it, what is the average age that we are referring patients to you? It's sad. I mean, the vast majority of kids are beyond 60 days. And it's not surprising. You'll never get an Indian data paper. You'll never get an Indian pediatric surgical data paper. I look for it every few months for a presentation and I get none. And the reason for that is because the referral is so late. What do we expect when we refer to you at 80 days, 90 days? I mean, you have wonderful surgeons with great sets of hands, but you are not magicians. I mean, when there is cirrhosis that's established, what are we going to get out there? And the other thing, and of course, I'll perhaps talk about it, and I don't want to take time from Zamir, but we have to realize that biliary atresia is a disease of the poor. And that is why you see horrendous cholangitis. In 27 years, I can barely count kids that I've seen who come from affluent families. So, you go ahead and do a Kasai, and then despite what you might do, what protocol you might follow, steroids, early age, prophylaxis, cholangitis is way more common in India than you see in the West. And every episode of cholangitis pushes the liver down towards the road of decompensation. And that's something, again, that we have to get our arms around. But enough said, I shall speak when my turn comes.
Well, Kanishka?
Yeah, I think we'll move on to the next lecture. Dr. Edkar?
Yeah, so shall we? So I presume Dr. Zamir would be giving us the next talk. Dr. Zamir is a consultant pediatric surgeon and a solid organ transplant surgeon at Narayana Health City, Bangalore. Without wasting much time, please proceed for your talk on pediatric liver transplantation. Dr. Zamir.
Yeah, hi. Am I audible?
Yes, certainly.
Yeah, okay. Slides are seen?
Yes, your slides are seen as well.
Okay. Good evening, everyone. First of all, at the outset, I would like to thank the organizers to give me an opportunity to speak here. Without taking much time, I think I would straight away move on to the topic of pediatric liver transplant. Where are we? What is its role in today's scenario? And what are the outcomes? I would try to keep the topic of liver transplant as simple as possible because we have medical folk also with us. And I would try to keep it as simple as possible and try to touch the basic aspects of liver transplant in pediatric surgery. Okay, so in the topics I would cover is basically the indications, contraindications for liver transplant, various types of transplant, various sources of organs, the complications, and in the end, I would like to share our experience at NH and to share the outcome to say where are we and how good, how bad is liver transplant in today's scenario. pediatric liver transplantation, all of you know, is a well-established treatment for children with end-stage liver disease. The first liver transplant was done by Thomas Charles in 1967. The patient had actually died on table, but that transplant was actually a whole liver was transplanted into a child. The splitting technique of liver, that is the time we came to know the anatomy of liver, that the liver has multiple segments which have their own blood supply and drainage, which are independent, and we can split the liver and
Dr. Jeevan Patel, sorry, Dr. Zamir, Dr. Jeevan Patel needs to be muted, please.
Yeah, thank you. So the moment we came to know the splitting technique of liver is possible, that was the time which radically changed the outcome in pediatric liver transplant. At present, there's significantly higher survival rates as compared to what it was when it started, primarily because of surgical techniques and good immunosuppressive regimens. If you look at this, the indications for pediatric liver transplant in pediatric age group is primarily cholestatic jaundice, where you take it less than 2 years, less than 15 years. Almost 75% of all the liver transplants that are done in children is basically patients with biliary atresia. Most of them have undergone Kasai, but as we have seen, the overall outcome is not very good. 50 to 60 to even 75% of the patients, sometime or the other, end up requiring liver transplantation. What are the contraindications, or I would say, what is the hurdle of liver transplant in biliary atresia? Uncontrolled infections, sepsis, cerebral injury, all these are all very relative indications, relative contraindications. But I think the biggest hurdle that we come across as liver transplant surgeons in biliary atresia is availability of the organ, availability of a liver, and affordability. I think Dr. Anupam has just said that most of the patients with biliary atresia are not from the affluent families; they are from the poorer families, and then they end up having significant infections, and they are the ones who end up requiring transplant and unfortunately are not affording it. So I think the biggest hurdle for transplant is not any medical, it is more of social and logistic reasons. Okay, coming to liver transplantation is basically an orthotopic transplant. Basically, orthotopic means we have to remove the native liver and put a new liver in that place. Kidneys are heterotopic. You can put a kidney in the right iliac fossa and plumb the vessels into other vessels. But liver, because has characteristic of its anatomy, you have the portal vein, you have the outflow into the IVC, which makes it possible only in the orthotopic position. Also, in children, as I said, most of the patients are biliary atresia, 1.5 years of age. So for them, and liver being an exceptional organ of regenerating capacity, a small segment, that is generally we take the left lateral segment of the adult, which is about 1/4 of the liver. This is the left 1/4, which is sufficient for the child. So pre-operatively, generally we measure the weight, we do the volumetric analysis of the liver, and we measure what is called as a graft versus body weight ratio, which has to be about 2 to 3%. And most of the time, a small 1/4 left lateral segment of the liver of the donor is sufficient for the child. What are the various types of transplant? I think we have come across, we do whole liver transplant in pediatric age group is generally very less. That is when we have an age matched liver. So that is rarely happens when you have a small child who is donating a liver because of brain death issues like a cadaver. We have most of the time it is reduced size liver transplantation. As I said, it's the left lateral segment, or sometimes when you have a cadaveric transplant, cadaveric organ, we use a part of the liver because that is sufficient depending upon the weight of the child. Next one is split liver also is done. It is not very rampant in India, but in certain other countries, it is the norm. Split liver, basically, I'm talking about cadaver transplant, in which the liver is split into two segments, each with its own blood supply, drainage, and biliary system. The bigger one is given to an adult, and the smaller one is given to a child. So actually, one liver is used for two patients. So these are different, these are different types of transplants that can be done. How do we match donors? In simple, unlike kidneys where you have to do HLA typing and all, the simplest thing in liver is basically the blood group. Most of the time, if the blood group matches, one can do a transplant. But then again, one has to do to see the imaging, one has to do make sure that the vascular anatomy is appropriate for a transplant, especially if you're taking a left lateral or a split of liver. Sources of the organs, as I was been telling, the most common source of organ is basically either it is a deceased donor or a living relative. Now, deceased donor is basically the organ donation program in which somebody who is most of the time has undergone had an head injury, other organs are fairly well, the patient is basically brain dead. So if a parent or if the relatives have given permission for organ donation, that is when the transplant process continues. In these conditions, what happens is the transplant team, the one who gets the liver, basically goes to the area where the goes to the donation site. They harvest the organs and they bring it to the respective hospital, and then they transplant the team. That's how organ donation and a disease organ program works. On the other hand, excuse me, just one sec. Quickly, pardon me. I am so sorry. Living related is the most common type of transplant that is done in India. It's almost 80-90% of the transplants are basically done by living related. As I had said, now we know the anatomy of the liver, and in these conditions, one is able to split the liver either as I said, in children, most of the time it is a left lateral segment. Little older children, maybe 10, 12 years old, 15 years, left hepatectomy or right hepatectomy can be done, and the liver is sufficient for the child. And the best part, as I said, in liver is the liver regenerates. Even in the donor, the liver grows, and it is sufficient for both. In simple terms, the transplant, I would not go into the intricate details of the surgery. The basic concept of transplant is you expose, you see how the liver in patients, especially with biliary atresia, extensive regeneration, extensive cirrhosis, extensive bile leaks. We have very bad livers. We remove this liver, that is explant liver, put back a fresh liver, and plumb the vessels, basically the hepatic veins, portal vein, hepatic artery, and the bile duct. Once this is done, the transplant is sorted.
This from Bangalore.
If you actually look at the complications that we come across, as I said, in transplant, this picture says it all. Liver transplant post-operatively is a very, very stormy course. We come across various complications, especially in children. The early complications, I'm sure the medical aspects would be taken up by Dr. Anupam Sibal, but the vascular early complications, primarily because of non-function, vascular problems, rejections are there. Many times you have to take the child again to OT and sort out the problems. In the Indian scenario, you come across late complications of rejections, infections. So it is not an easy task. The surgery itself is 8, 10, 12 hours of surgery. And then post-operatively, it is very stormy. One day you feel the liver function is doing well. Next day there is a problem. You keep doing Dopplers every day. Keep a close watch on the blood flows. Keep a close watch on the coagulation parameters. So it is not easy. So, and if you say that liver transplant is such a complex procedure, it is a long procedure, and you have so much of problems and so much of you want to go ahead and do the transplant. So I would just like to share our experience of the last 100 cases that we have done and highlight the fact that it is a great thing that we do. In NH, Bangalore, we have done more than 100 transplants, also 3 retransplants. The average age is smaller children, 5 months to 12 years. If you look at the weight of most of the children, it's about 5 to 10 kg. This is primarily again because most of our patients are biliary atresia patients who have or not undergone Kasai and have had recurrent attacks of cholangitis, and we have operated them at less than 1 year. So the weight has been very less in most of these patients, making the surgery again more complex. 60-70% of the indication of all the transplants that we have done again is primarily biliary atresia. The donor profile, as I said, was almost 90% is all living related, most of them being mothers. The difference what we have seen in the society as of now is initially it was only the mothers who were coming forward. Fathers, basically being the bread earners, said we cannot undergo major surgeries, but of late the fathers also have gone up. Second thing is the deceased donor definitely is about 9 to 10% is very less. But then again, in today's society, organ donation is catching up. People are becoming more aware, and definitely it is increasing. And we do hope that this process, this segment of donation significantly increases. What happens is if you do a deceased donor transplant, you are not subjecting a normal person to undergo any surgery for donation. So it is a very good thing that one has, but I think the awareness needs to grow among the society for this. Surgical complications, we've had our share of major problems. As I said, most of the patients have biliary atresia, very small babies, small vessels. Many times the biliary atresia, the hepatic arteries are very fibrotic, leading to more problems of hepatic artery thrombosis, associated bile leaks. So all these problems are there. Medical complications, I'm sure Dr. Anubhav will talk, but there is a big list. Significantly, primarily, initially, we have problems with infection, late problems in the Indian scenario, developing society, tropical society, we see all kinds of infections. You see tuberculosis, you see fungal infections, viral infections. A big list of problems post-operatively is primarily because of the immunosuppression. PTLDs is one thing that we see, renal failures is one thing that we see. But if you look at all this, despite all this, the liver transplant positively impacts the catch-up growth. All the problems that I had said before, be it surgical or medical, can be taken care of. And if they are done properly, the patients do very well. The catch-up growth, as I said, all these patients, about 5, 6, 8 kgs, that too, at the time of transplant, they're all bones, significant ascites. Okay. But after transplant, there is rapid growth in the first 1 year. They catch up growth as compared to all other children by 3 years. And by 5 years, their growth has been sustained. So this is one big positive impact the transplant makes on all these patients. If you look at the outcome, our scenario also initially the survival was less, but then we have also, our program also has improved, and the overall survival as of now is about 80%, which is quite good. This 80% includes acute liver failures, fulminant hepatic failure patients as well, whose outcome in the literature comes about 50-60%. But if you include the living related planned surgeries, it is almost 85 to 90%. So the overall outcome has been very good in all these patients. The Kaplan-Meier survival graph actually says that the mean patient survival is almost 14.5 years post-transplant, which is a good thing. A small note on transplantation in biliary atresia, as I said, is the most common indication. The problems that we come across is most of them are less than 1 year, less than 10 kg. A lot of studies have said that transplantation in children less than 10 kg and more than 10 kg significantly impacts the outcome. At least it significantly increases the morbidity and mortality. A lot of patients of biliary atresia post-Kasai, post-surgery, post-significant surgery, so explant surgery is very complex. And as I had said, normal vessels, smaller vessels make the vascular anastomosis more complex. But one thing, a lot of studies have still come up and said that if all goes well, then the overall outcome of liver transplant in patients with biliary atresia and other conditions is similar. So even though there are a lot of problems, a lot of issues that are there for doing a transplant in biliary atresia, the overall outcome is still quite good. So in the end, if you see what keeps us going is we see patients like this initially who are very, very sick, but after the transplant, after a year, after 5 years, after 10 years, they all grew up, they go back to the society, they are going to schools, they are going to colleges, just like any other normal child. So in the end, I would like to say that the biliary atresia with end-stage liver disease, transplant is the option. It is an established treatment for end-stage liver disease now, and it has good outcomes. But one thing one must remember, especially in patients with biliary atresia, is it needs early referral. With that, what I mean is if you have a patient with biliary atresia with end-stage liver disease, whether it is pre-Kasai or post-Kasai, you have recurrent attacks of cholangitis, you have the jaundice being high, you have bilirubin not coming down, enzymes are low, patient has features of portal hypertension, ascites. These patients need to be referred for a transplant center sooner rather than later. Also, during the workup for transplant, I think the nutritional status of these patients has to be taken care well. If at the time of transplant nutritionally well, then the overall outcome has been really good. Thank you.
Wonderful talk, Dr. Zamir. I think now we have time for a few questions. There are some in the chat box that Dr. Kanishka, do you have any comments to make? Dr. Kanishka?
Yeah, I was just seeing the figures, and it is so enthusing to see the figures in Narayana, which is a major center that we know of where the transplant goes on, and so it is so heartening that the figures of survival have gone up, and it is 1 year. It's 80% at 1 year now. Who wants to go in for this procedure? Yeah, I don't have any other comments. Are there any comments from the chat box?
Dr. Zamir, no, I tried to look that up and I couldn't find any. How many of your transplants were primary liver transplants which did not have a Kasai portoenterostomy done?
We have sort of 100, I think about 35 to 40, 30 to 35. I don't have the exact details as of now, but I think roughly it's about 30, 35 patients have undergone transplant primarily without Kasai. I think one thing how it works out for us is being a transplant center, we have an option for transplant, and that significantly helps us, whether we are biased towards it or not, I'm not sure. But we do come across patients who are maybe even 80 days, 90 days, 100 days, 120 days, whom we take up for IOC, we take up for Kasai, but on table, if we find significant nodularity, if there's ascites, there's significant neovascularization of the liver, we don't proceed with Kasai and proceed for transplant. So we do have a set of patients.
Wonderful. And do you have a kind of comparison between the ones who've had primary liver transplant and the ones who've undergone liver transplant post failed Kasai? Okay. Do you have a comparison to see which one, or maybe, you don't have an analysis, but do you have a, idea of which one does better? And is there a justification for it?
I think we have analyzed all our patients with biliary atresia, without biliary atresia, and in biliary atresia who have undergone Kasai and who have not undergone Kasai. The numbers on the other side is significantly less. So I think that statistical analysis was not appropriate at that time. But couple of things what we have found is the patients who have undergone Kasai, intraoperatively, the explant has been very, very difficult because there's significant adhesions, there's significant portal hypertension, which leads to a lot of bleeding. So bleeding is one thing we have had intraoperatively at the time of explant, especially in patients who have undergone Kasai. On the other hand, patients who have not undergone Kasai, the explant has been fairly simple procedure. But nevertheless, if things go well, the overall outcome in both the patients has not changed significantly. So I think from our side, we still hold fact that if a patient is biliary atresia, as Dr. Arvind sir said, there is no specific day, there's no specific age limit for this. For us, we keep it very simple. Whether a patient with biliary atresia has end-stage liver disease or not, has a liver cirrhosis or not. If there is cirrhosis, needs transplant, even if it is 80 days. On the other hand, if a patient, even if 110 days, liver looks okay, I think Kasai is the first thing that we need to do.
Fantastic. Fantastic. So, Dr. Kanishka, do you?
I think that also in the light of this, that we are a country where transplant has come up, but for it to be available to the large majority will take time. It is going at a good pace, but the study that Arvind mentioned, that where a Kasai can be done and may be done, because somehow the ones in whom the Kasai is done, at least the survival is closer to the group where rather than the group where it is not done, and they deteriorate rather than going in for the transplant, or they go in for the transplant later. So that is one thing that it serves as a bridge, and that bridge will stay for some time to come till we have that many transplant centers. So that is also something to be kept in mind as a public health perspective. I think with this, we will go on to the last lecture.
Certainly.
It's my pleasure to introduce Dr. Sibyl. Well, I remember him from the late 90s and early 2000s when At St. John's, we did, Dr. Ashley and the group from Christopher did the 2 transplants at the same time. They had done the transplants in up north, and we had to exchange notes in conferences. And Dr. Sibal is a well-known pediatric gastroenterologist. And I must say that having a pediatric gastroenterologist around makes a whole of a lot of difference in the management of pediatric liver disease and others. So over to Dr. Sibal. He doesn't need any more introduction.
Thank you. Thank you so much, Kanishk. Great to be with so many friends from pediatrics, neonatology, and pediatric surgery. Big hi to Rajiv. Big thank you to Ramesh, Sushma, Vikesh, and Surinder for this kind invitation. Really enjoyed the talks by Uma, Arvind, and Zahir. And I shall now start sharing my slides. Just one sec. Just a second. Just bear with me.
Is there any difficulty you are facing?
Yeah. No. It's just, can you see my first slide?
You're on. We can see the slides.
Yeah, great. So I'm just going to walk us through the journey pre and post-transplant. Typical what we see in the outpatients several times a week now. 11-month-old baby, pale stools since day 10 of life, jaundice since 2 months of life. So, we've already lost so much time because nobody asked about the pale stools in a routine examination postnatal. Another 1 month gets wasted, diagnosed with biliary atresia at 3 months. Another 15 days get wasted before they send to a pediatric surgeon, and a Kasai's portoenterostomy is done at 3.5 months. Jaundice persists. The child, of course, is incompletely vaccinated, presents to us at 11 months with weight 5 kilos, length 62 centimeters, both less than 5th centile, with abdominal distension, a bilirubin of 22, direct 14, deranged clotting. This is what this baby looks like. You can see the big scar there. And this is not typical. This is a scenario that we face day in and day out. Another severely malnourished child, now on nasogastric feeding. This is someone we are transplanting today. Again, had to put the child on nasogastric feeding. You can see severely malnourished. So this is what we have to grapple with. Here's another example. So the importance of nutrition in biliary atresia is not that appreciated by the community at large. If we look at nutrition in chronic liver disease, about 25% of children with chronic liver disease will have malnutrition, of course, higher in developing countries. But when we talk about biliary atresia, it's virtually 100%, when they come to us. Early diagnosis and appropriate nutrition is critical. We know that if you transplant a child who's malnourished, there is greater morbidity and the mortality rate is definitely higher. So the moment you see a child with a failed Kasai and has decompensation, it's extremely important to focus on nutrition, give MCT supplements, and make sure there's enough carbohydrate, protein, and fat in the diet, the energy is adequate, and we supplement with water and fat-soluble vitamins. Vaccination, again, very important. We published this in Indian Pediatrics a while ago. 2/3 of the potential liver transplant patients that we saw were partially immunized. And the reason for that is that the moment the child's jaundiced, the attention focuses on other aspects, and vaccinations kind of not given the priority that it deserves. So when one is dealing with a child with a failed Kasai, who's going to go down the liver transplant route, I think it's extremely important for the pediatrician to advance vaccination. So we are talking about vaccinating, say, a 6-month-old with the chickenpox vaccine, MMR vaccine, though you're supposed to give it at 9 months and 12 months. And we do understand that the efficacy is doubtful, but it's better to at least stimulate the immune system and get some kind of a potential for some immune reaction should there be clinical exposure. And of course, we have to wait for 4 weeks after we give a live vaccine and the transplant, because on the day of the transplant, the child's going to start getting immunosuppressed. It's extremely, extremely important that every pediatrician, and for that matter, every pediatric surgeon, gives consideration to the fact that if the jaundice hasn't cleared 3 months after a Kasai, this child needs to be referred. It's not that the child is going to get transplanted the next month, but cholangitis needs to be managed if it develops jointly between the pediatrician, pediatric surgeon, or the pediatric gastroenterologist.
We've lost your audio.
We have lost contact. It should come back.
Anupam, can you hear us?
Maybe we should ring him up and tell.
Yeah.
Vikesh should ring him up and say.
Yeah, I'm doing that.
Yeah.
Yeah. I was able to convey to his secretary.
Okay, let's so he gets back.
On 90 minutes, suddenly when I need to speak, it goes off, but no problem. That's something that happens with liver transplants. So it's kind of in keeping with so will liver transplantation be possible? And the three distinguished speakers have kind of addressed some of these questions, the big doubts people had. Will parents can you hear me and see me?
I can hear you and see you, but your slides are not there.
Okay, let me just. Yeah, somebody's disabled my screen sharing.
Yeah, I'll just.
Sorry, Anupam, you can just talk, because I think you can carry us through what your messages were.
No, sir. I'm making you co-host again, sir. I'm making you.
Yeah, somebody took my privileges away. Also happens.
Not as a group director, I presume.
One second. Sorry about this.
Now you can share your screen.
Yeah, I'm doing that now. Yeah. Okay. So I was saying, so, will it be possible? Will parents donate? What about the bias against the girl child? And who can understand this better than pediatric surgeons? Because you see the mismatch between boys and girls in the neonatal and pediatric surgical work, and liver transplant will only be for the rich. So the first 10 years were very hard. We saw patients who were referred to us very late when they just had a few days to live. And as a result of which only 95 children in 10 years were fit for a transplant. Most families talked about it, but were not willing because they felt that it was too much of a commitment and they weren't very sure about outcomes. So only 40 families were willing, and out of these, only 16 could be transplanted. And in that 10-year period, 88 adults were transplanted. So a pretty rough ride there. And there were just so many roadblocks, and it was like banging your head against the wall. But finally, as happens in India, the wall cracked. And when we look at our data after that, you can see what a radical difference. If we look at pediatrics, 609 referrals, 564 families willing, 535 transplants, and at the same time, on the adult side, we did 3,943 transplants. Bias against the girl child, very evident. 72% of the transplants initially were in boys, only 27.8% in girls, but we are so happy now the ratio is nearly equal. 51.7% boys, girls 48. I'm pretty certain that the girls will overtake the boys in the next couple of years. Gandhiji had said, a man can never be a woman's equal with the spirit of selfless service that nature has endowed her with. We saw that. When it came to donation, it was just moms, 70%. Again, we published this, and finally, men felt, parents and granddads felt that it was a worthwhile investment. And we got the ratio at 50-50, which is where it is now. And we published this a few years ago. The paradox of transplantation is getting this balance right with immunosuppression, and we tend to use tacrolimus and mycophenolate and steroids. I think with time you get better, and you don't want to over immunosuppress because then you have the risk of infections, tumors, PTLD, and of course, if you under immunosuppress, then you're worried about rejection and recurrent disease. So this is an art and a science, and it takes time. It takes years to get this balance right. And we now have become better than we were when we first started. Some of the complications have been alluded to. Of course, the first few days you can have graft non-function, you can get sepsis, you can get problems with venous thrombosis, arterial thrombosis, and then as time goes by, then other complications, something that you have to be watchful of. Graft rejection can happen at any point in time. So there's a list of surgical issues, graft dysfunction, infections, PTLD, metabolic issues that come up, catching up on vaccination, making sure that growth and nutrition is fine. And of course, as they become adolescents, then there are a separate set of problems with adherence. Now, this is interesting in that, and now, we've been doing this now for more than 25 years. And I can tell you this, that when the surgeon's done the first 100, there's a difference. When a surgeon's done 500, there is a definite difference. When a surgeon's done 1,000, everybody in the unit can see the difference. When a surgeon's done 1,500, it's a breeze at night for the fellows. And when you've done 2,000, well, then you can sleep at night in the ICU. And I say this because clearly there is a very steep learning curve. And I know that this applies to so many different pediatric subspecialties in terms of surgical branches. But in transplants, it's a huge learning curve. And the more experienced the surgical team, more experienced the medical, intensive care, and everyone together, and anesthesia, of course, the better the outcomes. So biliary complications can vary from 5 to 25%. Hepatic artery thrombosis 3 to 10, portal vein thrombosis 2 to 10, bowel obstruction, diaphragmatic hernias. And I'm very, very happy now that with hepatic artery and PVT, we are really at the lower end at 2, 3, and biliary is somewhere around 7 or 8%. Rejection is common, up to 60% might get rejection, but unlike kidneys, managing acute rejection in livers is relatively easier. And so we're not really perturbed about it. Chronic rejection, of course, is worrisome. Recurrent autoimmune hepatitis is a problem, so you need to get the immunosuppression right. Sometimes you can get de novo hepatitis. Recurrent PSC, it's not a common problem in children because PSC is not a common indication. Growth, extremely important, risk of fractures. We have had quite a few babies who've had fractures waiting for a transplant. So, vitamin D supplementation, making sure that calcium phosphate is appropriately given in doses pre-transplant is important, and also post-transplant. And so supplementation is important. One has to be cognizant of the fact that they sometimes tend to put on too much weight. You have to look at lipid profiles, you have to look at their blood pressure, you have to look at renal function. But it is very, very gratifying. So, this is one of our highest risk cases that we took. You can see the belly, you can see the malnutrition. This child had multiple bleeds and was really, really ready to die. And the team was like, should we not? But we went ahead and did it. The same child a year later, the same child 2 weeks ago when I met her 6 years later in Philippines. This child was the youngest that we had done. She weighed 3.8 kilos, and you can see her at discharge, and this is her 4 years later. So we've now got experience of more than 4,500 transplants, of which pediatric are 551. Biliary atresia is 302, in a wide variety of indications. A lot of the metabolic is Wilson's. We have a fair group now of PFIC, some unfortunate choledochal cysts who should never have needed a transplant, but, diagnosis missed, and, they've developed cirrhosis, some Budd-Chiaris, and then a variety of indications from poisoning, largely ratol poisoning, hepatoblastoma, and hyperoxaluria requiring a combined liver kidney transplant. But I want to spend the next 5 minutes or so really talking about something that has been alluded to. Kanishka mentioned this also. Everyone's mentioned this. How do we actually make this accessible? So, when we first started off, I think the first 15 years was about getting the program going. And then it became very, very clear that, yes, we'll be able to do 15, 20 transplants a year when the need is so much. So is this good enough? What is it that we do to reach out to those with no resources? We all know that we live in India and we live in Bharat. So we have patients who can go to Disneyland for a holiday, sometimes more than once a year. And then we have families for whom just bare essentials is hard. We have kids who have the fanciest of birthday parties, and then we have children for whom getting 2 square meals is a challenge on a daily basis. So how do we reach out to those who need us the most? And especially, for the pediatric surgical community, it's about biliary atresia, because these kids are from very disadvantageous families. I mean, we all know that. So we started to strategize. What can we do to get to these families and help them? So we reached out to temples, zakat, church, gurdwara, charities, crowdfunding, paid forward concept that we see in communities, individual donors. Our acute liver failure, liver transplant packages at 15 lakhs. Standard risk is 13.5 lakhs. So we felt that if we were to halve this and make it less than half at 6 lakhs for babies with limited means, we'd be able to do a lot more transplants, and surely it helps. We also explored crowdfunding, like this child, much older child with autoimmune hepatitis, came from a village in Kashmir, and she came on the back of a vegetable truck because the family couldn't afford bus tickets from Srinagar. We raised so much money for this family that not only could we transplant the child, but with the extra money, a house was made for the family in the village, and they did not have a proper house. But what happened, and this was, as you can see, 2019, and we figured out that this is not sustainable. There are too many demands when it comes to crowdfunding. You have the whole cardiac, you have onco, you have the rarest of rare diseases, and this was not sustainable. So, we couldn't really rely on crowdfunding. So we thought of reaching out to people who believe in St. Francis's philosophy of it is in giving that we receive. So what we started doing was that we approached affluent families who kids we had treated for normal medical conditions, and said, would you be able to support us? And we were surprised. We were surprised that we had so many families come forward with commitments. So as a result of which, we now, if someone has a BPL card and they have zero resources, they will get transplanted in our program. I'm so happy to share with you that we have raised 24 crores through charity in the last 5 years. 24 crores for pediatric liver transplants. And we've been able to get our numbers going because of this. So last year we did 57 pediatric liver transplants. And at least 40 of them got some support. Some got a lot of support, some got 2 lakhs, 5 lakhs, and some got virtually the 100% support through very generous individuals who support our program. I'm just going to give you 3 examples. This child's father has a very small shop in Varanasi, earns 10,000 rupees a month. And when this family approached us, they were so scared that, why are we even coming here for a liver transplant? And I think they spent all of 50,000 rupees in a guest house where the family stayed, and the entire transplant was sponsored. And this is this child, a few months later. This baby is from a small village in Jharkhand, and the father works as a daily wage laborer. This baby was born after 8 years of marriage. Mother's, of course, a homemaker. And again, this family had no resources, zero resources. So they spent 0 rupees of their own. And this is him a few months later after a transplant. And this little baby came to us from a small village in Andhra Pradesh. Her father works as a driver. And again, with earning of less than 15,000 rupees a month, there was no way they could afford a transplant. And again, the entire transplant was taken care of. And I can give you many such examples of babies with biliary atresia. And this is her about a couple of years later. And of course, I'd like to end with Sanjay. Sanjay from Kanchipuram, the first child to have been transplanted successfully in India. Biliary atresia, Kasai done. At a later age, the jaundice didn't clear, and this is him at about 20 months, severely malnourished, deeply jaundiced, extremely irritable. He was the first child to have undergone a successful liver transplant in India, a living-related liver transplant with the father being the donor. And talking about stormy courses, this child had the most stormy course that anyone can imagine. So he had a Kasai, he had a transplant. Day 4, he develops abdominal distension. We believe he's got a perforation. We open him up, we find a perf. Not surprising, lots of additions. Post Kasai, fine. Goes on to a vent, we make him NBM. 3 days later, he develops another perforation, has another laparotomy. He ended up having 4 laparotomies. He was in a vent for 7 weeks. He was on TPN for 8 weeks. So we were really delighted when he went home at 100 days. And this is him at discharge with his father. This is him a year later at the All India Transplant Games. 3 years later. 6 years later, 9 years later, 12 years later, 15 years later on the cover of the Week magazine. That's when a postage stamp was issued marking 15 years of liver transplantation in India. He then decided to become a doctor, and at the age of 19 enrolled into a medical college, graduated, works now as a doctor in Chennai. And a few months ago, this is him at the 25th anniversary with Dimple Kabadia, and then he just got married. So that really is the story of liver transplantation. So a baby born in India in the 1950s with biliary atresia had 0% survival. A baby born in 1998 had a 20 to 30% chance of leading a normal life with a native liver thanks to a Kasai protoenterostomy. A baby born today has more than a 90% chance of 20% and more a year survival. We just looked at our data a few days ago. So our overall survivors are 87%, and this includes transplants that were done 15 years ago. And we then looked at our last 150 and last 300 transplants. For the last 150 transplants, we are looking at 93.7% survival. And I'm pretty certain that our 8-year survival, when we look at the analysis, is going to be upwards of 90%. And I think that's going to, as has been the data from Japan now, from Korea, from Europe and America, that after the first 10 years of a program, you compare the first 10 years and the next 10 and then the subsequent 10, your survival figures of 10 years are going to be in the high 90s. And this is really gratifying to see how the prognosis of biliary atresia has changed over the last several decades. A big thank you to the pediatric surgical community, because our program would be anywhere without your support. And thank you so much for continuing to support us as we continue our mission to reach out to those who have no hope. And today, I can say with a great deal of satisfaction that if we see a child and the child has a donor from within the family and has a BPL card, we will transplant this child. We have removed money from the equation of transplantation. Thank you so much.
Thank you. That was a wonderful overview, not just the medical aspects, but also the human aspects. And it is lovely that you ended with the story of Sanjay, which actually gives us a lot of hope that there is a lot to come in this country. Well, I have one question. For a layman, when they come to you and say, is liver transplant like kidney transplant, and you want to put the cards in front of them, how would you compare the two? a liver transplant in a child to a kidney transplant in a child?
Yeah, I mean, a great question. And, because we do kidney transplants as well, reasonable numbers that follow. So technically, and you are a pediatric surgeon, so I mean, most of the audience is pediatric surgeons. Kidney transplant is a walk in the park surgically compared to a liver transplant. But a kidney transplants, the long-term issues with rejection and the fact that you're going to need another kidney in 8 to 10 years really complicates things. So that's why the kidney transplant numbers everywhere in the world, they just don't take off, because how many kidneys is someone going to have over their lifespan? Managing rejection with kidneys is hard. Managing some of these viral infections is harder. The liver that way is an immune privileged organ. You get rejection, you can manage it pretty well. In fact, clearly it's been shown that when you do a combined liver and small bowel transplant and compare that with small bowel transplant, rejection's much better when you've done a combined. So there's an advantage that the liver replacement brings in. So clearly, kidney transplants easier, it's cheaper, but long term, it's a lot harder. In a liver transplant, long term is very, very gratifying. There were a couple of questions, if I might, Ganesh, with your permission, answer. Of course,
Sure.
Lots of appreciation. So big thank you for that. In terms of how do you manage the Sanjay was, we managed to get sponsorship for Sanjay for immunosuppression for life from the company, because he was the first kid. But now it's not a problem. Every government hospital gives immunosuppression. We will not do a transplant unless we've tied up with a pediatrician, because I give you examples from small villages in Jharkhand, in Andhra Pradesh, in Telangana, in the Northeast. So we tie up with a local pediatrician, and all government hospitals, I mean, the large teaching government hospitals can prescribe immunosuppressions given. So not a problem. And, if they have some of the other problems and they need to come in, and sometimes, you need to stent them because they develop a biliary stricture or something like that, then we will find the resources to be able to do that. There was a very interesting question as well. Pediatric surgeons as transplant surgeons. So where can you train? Now, as we all know, it's a huge commitment, and you really want to be busy. So are you going to be happy? We do 57. So we do more pediatric liver transplants than anyone else. There are hardly any, a handful of programs in the world that do more than 50. But I don't think any pediatric surgeon is going to be happy doing 50 surgeries, even if they're 12-hour surgeries and some of the other complications. So, unless you're doing kidneys and you're doing, some other hepatobiliary or other work, you're not going to be happy as a surgeon. So, it's a career call that people have to take. And that's why they're like, a handful of, I think, you can count on your fingertips the dedicated pediatric transplant surgeons in the world. The volume is just not enough.
Right. I think with that, we have come to the end of this. Over to Dr. Vikesh for the rest.
So, of course, it was a very enlightening session, and there are take-home messages. One which is very important is we need to build the bridge, as Dr. Sibal said, and that was the sole purpose of this collaboration. Early referral from a neonatologist to pediatric surgeon is as important as early referral from a pediatric surgeon to liver transplant surgeon. So I think with this take-home message, we will take this collaboration further. And
we've lost you, Dr. Vikesh.
Pardon, sir?
We can hear, sir.
No, we can hear you.
Yeah.
Go on, Vikesh.
From bottom of my heart and on behalf of IAPS, I thank all the speakers and both our moderators, Dr. Redkar and Dr. Kanishk Das, and all the audience for actively participating in this meeting. Thank you very much.
As from NNF part, thank you, Vikesh, for organizing it. And I'm really must mention name of Dr. Meenu Vajpayee, sir, who could bring this collaboration to this fruitful, you can say, fruition. And we are now hoping to do more such programs together, Dr. Anupam. I think pediatric surgeons need to, in fact, in next constitution, we have given them a special place to make all our pediatric surgeons as very active members of NNF, and this collaboration should continue as it used to occur in past.
Wonderful.
Thank you. Thank you very much.
Thank you.
Have a nice
Thank
day.
you. Thank you, Dr. Anupam. Thank you, Uma.
Thank you.